Hi, everybody. Welcome to a session entitled The ABCs of Papillary and Follicular Thyroid Cancer Invariants, Understanding Key Terms, Concepts, Initial Diagnostic, and Treatment Steps. My name is Matt. I am a 11-year papillary thyroid cancer survivor from Seattle, and I'm here to introduce Dr. Priyanka Iyer. Dr. Iyer is an oncologic endocrinologist and assistant professor, Department of Endocrine Neoplasia and Hormonal Disorders, Division of Internal Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. She received her medical degree from the Armed Forces Medical College, Pune, India, and completed her residency at Johns Hopkins University. And with that, I hand you off to Priyanka.
Thank you so much, Matt, for the nice introduction. And I would like to keep this informal. I'll be going through slides, but please feel free to interrupt, ask questions, because this is for the benefit of everybody, and I'm hoping it is useful. All right, so to begin with, as we all know, it's important to have a multidisciplinary approach for the treatment of thyroid cancer per se. And if you attended Dr. Alan Ho's session earlier, he did mention about how we all, put our brains together, think about it, temper each other's over enthusiasm, and make sure we offer the best treatment to our patients. But keeping in mind at the center of the focus is the patient and their family. The team essentially includes the surgeon, the endocrinologist or endocrinologist, nuclear medicine doctor, pathologist, primary care doctor, genetic counselor in cases that are needed, radiologist, and of course, medical oncologist in some situations. So let's start with the anatomy of the thyroid gland. For those in here, you probably already read about it, seen about it, but just a quick overview. So this is the thyroid cartilage, and that's not what the Adam's apple that we see. That's not the thyroid gland. It's the thyroid cartilage. And then this is the cricoid cartilage, and the thyroid gland is actually much lower. And that when if enlarged, or if you have lumps there, it's seen if it's a large enough lump. If not, on clinical exam, it's typically palpated. So the thyroid gland on the backside has four little tiny glands known as parathyroid glands. And I always wish that the scientists had named it something different, because most patients confuse between parathyroid and thyroid glands. But actually, they are like neighbors living in townhomes. They share a wall, but they do not talk to each other. So take it that way. So they sound similar, but they're really independent and do very different things. So when you say, or when somebody says they have a goiter, what that means is that their gland is really enlarged, and it could be that the entire gland is enlarged or only a part of it is enlarged. And when if you take this out and look at it under the microscope, this is what it looks like. Multiple little lakes or pools of colloid or thyroglobulin. And these are the follicular cells that you see, and in between those are the parafollicular C cells here. And they have, again, very different functions, and they give rise to very different types of cancer. So the thyroid in general has two lobes connected by a bridge or an isthmus, with or without a pyramidal lobe. And the gland, like I said, it is organized into follicles containing colloid. The follicular cells, they have a very different function from the parafollicular C cells, which secrete calcitonin. The follicular cells are the ones which really make the thyroid hormone, that is your T4 and T3. And the parafollicular cells make calcitonin, which is important for calcium reasons. Now, control of thyroid function, a quick overview here. So this is the hypothalamus located higher up in the brain, and that releases some hormones which stimulate the pituitary gland. This is the thyrotropin releasing hormone. This stimulates the pituitary gland to make the thyroid stimulating hormone, or the TSH, which your doctors watch closely. And this TSH stimulates the thyroid gland to make T4 and T3. And it's the T3 that then talks to the pituitary gland and regulates the TSH number. So again, looking at this, thyroid nodules can be of two types, as we know, benign and carcinomas. Obviously, benign nodules are something we don't worry about much. But in terms of carcinomas, the most common one is the papillary followed by the follicular and Hürthle cell. Then you have the medullary, which is rare. And what is even more rare is the anaplastic variety. How do we make the diagnosis? It's with FNA, and what we see here in a benign nodule, you see there's abundant colloid, the pinkish stuff that you see is all colloid. And then when you look at malignant cells, this is what it looks like. Like you see multiple papillary formation, multiple follicular cells here. And this is what MTC looks like. That is from the parafollicular C cells, which make calcitonin. They are more bluish in nature, bluish in color when you look at them under the microscope. And then you have the indeterminate thyroid nodule, or sometimes they report it as follicular neoplasm. And what it means is it has an abundance of follicular cells, but it's not very clear whether this is cancer or not, and needs additional testing or surveillance to confirm that. So then when you look at the staging systems, we have, so when you look at your reports that you get, it gives you a Bethesda stage, that is Bethesda 1, 2, 3, 4, 5, 6, so total 6 stages. And the 3 and 4 are the indeterminate ones, also known as a follicular lesion of undetermined significance, or also some people call it ACUS, or atypical cells of undetermined significance. Then there's a follicular neoplasm, or which is suspicious for, or it comes as suspicious for follicular neoplasm. So this comes in the indeterminate category. And why it is confusing for both patients and physicians is that it does have some risk of malignancy. Like you can see here, it goes from 6 to 18% and up to 40% for follicular neoplasm. So this is what we usually do for these patients. Typically you would either repeat FNA or watch it or offer a lobectomy if patients are more concerned and don't want to deal with potential growth to carcinoma. Obviously, if it is suspicious for malignancy or malignant, they're more inclined, and so are the physicians, to either consider a lobectomy or a total thyroidectomy, which means when the entire gland is taken out. So then we also have molecular tools available to study these indeterminate nodules further. And this is a little busy slide, but it encompasses all the tests that are currently available in the market. The ThyroSeq, Afirma, ThyGenex. And what it essentially tells us is whether it's a rule in or a rule out test. Basically, it helps us determine if this is cancer or not cancer. And then we do molecular testing to identify certain mutations, which makes it more likely to be cancerous. For example, your BRAF mutation, definitely cancer. NRAS mutation, 70% risk of cancer. So those tests really help us determine what we should do with this nodule, with this indeterminate nodule. Looking at a thyroid cancer cell, so if you see here, predominantly we encounter papillary thyroid carcinoma. That's a garden variety of thyroid cancer. 5 to 10% of cases of follicular thyroid cancer, and less than 5% medullary thyroid cancer. And these arise from parafollicular C cells. I'm not going to go into much details of medullary, since I was told to focus on the follicular derived for the most part, but I'm happy to answer any questions if anyone has. So what is cancer? We know it is a genetic disease, and we all know that all cells start as a normal cell when we are born and we grow, and then there is one mutation. But typically that one mutation is not enough to give rise to cancer, but it is a collection of all these mutations. So there could be one, and then it's hit by another one, a third one, and eventually it causes growth of malignant cells. So when you look at thyroid cancer moleculars, again, this is a busy slide, but this is what goes on in our mind when we see advanced thyroid cancer. And I treat advanced thyroid cancer, so this chart is virtually printed in my head. So when I'm assessing patients for, okay, these patients have had this surgery, they've had radioiodine, what next? This is the workflow that we follow. We try to understand, okay, where is the problem? What is the driver mutation? You remember I said there could be one mutation, there could be multiple mutations. So we want to see whether it is down the RAS pathway or the BRAF pathway, or it's a different pathway, the mTOR PI3 kinase pathway, or when we do moleculars, do they have RET fusion, or do they have a c-MET mutation? What is the driver of this tumor? And that's what we try to identify when we ask for molecular testing. Because when you know what is driving it, these tumors have a particular way of behaving. as in BRAF tumors are the ones that come more likely in the lymph nodes when they recur, whereas the RAS tumors are ones, they may come in the lungs as well as lymph nodes. But if it is a follicular thyroid carcinoma with a RAS, it's more likely going to come in the lungs first or bone. So that's why it's important for us to understand what is the molecular makeup, what is driving this cancer. So this is the evolution of thyroid cancer. It's pretty self-explanatory, but all of these, they arrive from the follicular cell. When they uh, develop mutations, and eventually they transform to either papillary, which if it advances becomes poorly differentiated, and eventually anaplastic. Similarly with follicular carcinoma, it can transform to poorly differentiated or anaplastic. And as this process happens, they acquire more mutations. So that means they may start with one mutation, like you remember the workflow that I had shown, but eventually as these tumors grow, they develop and acquire more mutations, which makes it behave more aggressively. Looking at the staging for thyroid cancer, this is a very commonly asked question. When I see new patients, they always want to know, what stage am I? Am I a stage 4? Am I going to die? Or is this something that I need to be worried about? And the good news is that up to 55 years of age, even if you have distant metastatic disease, that means even if it's in the lungs or in the bone, then the staging is only stage 2, which tells you that these cancers are usually very well behaved, slow growing, indolent. It's after the age of 55, again, where, that's when you really worry about. Distant mets is when it comes to stage 4A or 4B. But even with multiple lymph nodes, which we see very often with papillary thyroid cancer, you're still not a stage 4. So even if you keep getting lymph nodes, or you have a lot of lymph nodes at the time of diagnosis, it doesn't mean that you're a stage 4, or you're closer to death or anything like that, unlike some other cancers that people come across. What are the tumor markers in thyroid cancer? I'm pretty sure most of us are familiar with thyroglobulin levels. Your doctors probably check this every visit. So these tumor markers help to understand the disease status, but they're not the sole reason for pursuing either chemotherapy or systemic therapy or further diagnostic studies. So coming to thyroglobulin, we always get thrown off when we see thyroglobulin antibodies. And these usually exist in people who are pre-existing either Hashimoto's disease, or if they have an autoimmune milieu in their own body. That means they have other autoimmune conditions. And these can be confusing because the numbers are not very clear. Sometimes the antibodies will be up, sometimes the thyroglobulin will be up. So we have to take it in the clinical context. When we as doctors see patients, we look for the suppressed TG value and the stimulated TG value. So now what is the suppressed TG? That is the thyroglobulin level when your TSH is suppressed to the goal it should be. What is the goal? It depends on the extent of your cancer. So for some people, the goal TSH is 0.5 to 2. They are the ones who are in low risk category. For some people, it is 0.1 to 0.5, and that's the intermediate risk category. And then for some people, it is less than 0.1, and that's the high risk category. Now, to fit into those categories, what determines that is the surgical pathology. So when you look at the actual tissue under the microscope, if there is any evidence that this cancer is probably already spread elsewhere, like if there are blood vessels involved, then they come under the high risk category. But if it is a well circumscribed, or it's just confined to the thyroid itself, it's not spreading anywhere, then it's most likely low risk. Then what is the stimulated TG level? This number comes in handy, particularly when we are giving radioactive iodine. And this is important because we want to see how much does the TG go up when you either give the thyrogen, that is your recombinant TSH, those are the shots that your doctors give before radioiodine, versus withdrawal. So withdrawal is when you're asked to hold your thyroid hormone for 6 weeks. They'll put you on cytomel for about 4 weeks, and then 2 weeks or closer to the radioiodine, they will check a TG level. Now, this is more sensitive than suppressed TG, but this gets tricky when the level is between 1 and 10. So ideally, the suppressed TG value should be less than 1, and the stimulated TG level value should be less than 10. But it's again a gray zone when you see TG value between 1 and 9, but what does that mean? Or 1 and 10, and what does that mean? So you again have to look at it from a clinical context, or look for, is there anything truly reflecting that? So imaging comes in handy in those situations. So in terms of imaging, what we're looking at is ultrasound. We look for nodules, or, what are the features of the nodules? Are they well circumscribed, or do they look very, uniform, round? Or do they have some calcifications, or do they have some lymph nodes with some calcifications? So those are the features we are looking for. So ultrasound findings. So you often get ultrasounds done even after surgery. So what are we looking at? So what we're looking at is, what do we see? Do we see a completely clean thyroidectomy bed? That means you don't see anything. You just see the trachea and the musculature. Or do you see a nodule which is containing, just fluid? It is cystic. It looks benign. Like you see, it's well-rounded margins. Doesn't look like it's growing out anywhere. And this is again another benign colloid nodule, which is spongiform. This is important to understand because in patients, say, who have a lobectomy, it's a low risk cancer, you've had a lobectomy, you have thyroid nodules on the other side, but they're reported as spongiform. So what does that mean? It looks like a sponge. It literally means that. And there are no calcifications, looks very neat, rounded margins, doesn't look like it's extending outside. Then we have something we call pseudonodules. Now, these are very common in people who have Hashimoto's thyroiditis. And what that means is that, yes, they do look like a nodule, but they don't have very distinct margins. And they're not necessarily cancerous. They're just there from the autoimmune milieu that is present. And then you have the benign follicular adenoma, or just a benign tumor or a solid tumor, where you see, again, very clean, well-rounded margins, no calcifications, nothing concerning. It looks pretty neat here. So that's why we call them benign. And then you have the papillary thyroid carcinoma, where you see tons of microcalcification. You see all the white dots. It almost looks like, a picture of dandruff on a black t-shirt kind of a picture. And then here, you can't tell much in this image, but you can see that it is tall. This nodule is taller than wide, and it's kind of jutting out like you see here. Unlike the previous ones that I showed, they were well-rounded, smooth margins, and some of them may even have irregular borders. So when we look at the scan, and if it is indeterminate, for example, but on imaging it looks something like this, then we are most likely going to recommend either additional molecular testing or surveillance and possibly lobectomy. So CT scans, when do we do CT scans? We usually do that when we want to look for distant metastasis, like for example in the lungs, or if you're looking at mediastinal lymph nodes, you can see, like, if you nodules over here, then they are concerning for metastasis. Now, that is a scan that we do in some cases where the thyroglobulin level is high, but not everybody gets that before their thyroid surgery. In terms of thyroid surgery, is very basic information here. So which one you do what. So if it is a carcinoma, you would usually do a total thyroidectomy. If it is Graves' disease or benign thyroid disease, then we tend to do a subtotal thyroidectomy. And if it is just one nodule in one gland, we prefer a thyroid lobectomy, especially if there is a suspicion of a low risk cancer, or if it is large enough and causing issues to the patient. Now, these are the anatomic levels of lymph nodes. And the reason I mentioned this is because it's very important to have a good quality ultrasound. A good quality ultrasound not just looks at the thyroid bed area after surgery. You must insist that they look at all the lymph nodes. The ultrasound probe should go to under your chin, to behind your jugular, or your, the sternocleidomastoid over here. You see there are lymph nodes here as well. So there are 6 levels of lymph nodes that we monitor for. A lot of times when we see patients, they've had ultrasound surveillance scans, but they really haven't had a good look at the lymph nodes. And that's what centers which see high volume thyroid cancer, they tend to focus on. They really look for these lymph nodes. So then we come on to pathology. So why is pathology important? We obviously want to know what type of cancer is it? Is it papillary or follicular or poorly differentiated or anaplastic? You want to know the size because it goes into the staging. You want to know if it is unifocal versus multifocal. That means if there's just one focus of cancer or multiple. If there's extrathyroidal extension, that means does it go into the muscles outside the thyroid gland? Or is it invading any structures? If there's lymphovascular invasion, that means if there is a potential that it may have spread to the lymph nodes, or what are the margins like? Are they smooth? Are the margins involved? Did the surgeon get a good clean margin? So that's why this is important. And then we also have lymph nodes where you're looking at the location, which level was involved. We call it central neck or lateral neck. It was this cancer going outside the lymph nodes. What was the size of the lymph nodes? So these factors play a role in making the decision on radioiodine. So that's why we look at the surgical pathology and go from there. Now we come on to radioactive iodine or iodine 131. The half-life of this is about 8 days, and that's why we recommend isolation after that. It emits two types of particles. The beta one, which is the one that we use for treatment. The gamma, the low dose one, is what we use for diagnosis purposes. Then it's available as sodium iodide injected in capsules or a drinking solution. It's not like the radiation treatment or external beam radiation that we are familiar with. This is radioactive iodine in a very easy to consume capsule. So let's go a little bit into the history of radioactive iodine. I like history. I find it very fascinating to understand where did this come from? What is the story behind it? So I decided to put a little bit of information in. So it was originally produced from tellurium at UC Berkeley in 1938. And historically, it was used to treat patients in 1941 for those who had thyrotoxicosis. And what they found was that when they gave radioactive iodine, the excess of it used to stun the thyroid gland and over a period of time reduce the thyroid hormone production. Then in 1946, they started publishing papers in JAMA reporting that yes, you could use radioactive iodine for hyperthyroidism. And then moving forward, they found that in 1949, this was the first case where they found that a patient with metastatic cancer was treated by drinking 4 doses of radioiodine. So this was the first patient, and this was in 1942, and as he looks today. So this is how he looks now after the treatment. So it really made a big difference. This person had metastatic follicular thyroid carcinoma, treated with radioactive iodine, and boom, he is cancer free. So this was our original targeted therapy before we started targeting BRAF and this and that. This was targeting the iodine, using iodine to target the thyroid cancer. So important considerations include low iodine diet. This is very, very important because we don't want the iodine in your diet competing with the radiation. We want the radiation to do its job. So we typically recommend at least 10 days to 2 weeks before the actual treatment. There are 2 ways of doing it, withdrawal versus thyrogen. Thyrogen is definitely more expensive, and depending on whom you ask, some people prefer withdrawal, some people prefer thyrogen. In terms of efficacy, it's more or less the same. If you look at European studies, they say one thing, American studies say the other. My personal preference is thyrogen stimulation, mainly because when you withdraw thyroid hormone, patients don't feel good. And how my patients feel is very important to me. I know it's expensive, but we usually get it approved by insurance, so it's not been an issue. In terms of dosage, how do we determine the dosage? It's empiric dosing. That means depending on their surgical pathology, depending on what their diagnostic scan looks like, what their stimulated thyroglobulin or the withdrawal thyroglobulin looks like, we determine the dose. So we either go by that or we do something called dosimetry. Now, dosimetry is not routinely done, but what this means is, you remember I said there was that patient who got 4 doses of radioactive iodine? That's a lot. These days, we don't do that. Why? Because we found iodine can affect your bone marrow. It can cause other cancers. It can cause other problems. So dosimetry is a safe method. That means we determine what is the toxic dose to that patient's bone marrow, and we try not to exceed that dose. Now, where do we use this? We typically don't use it routinely because these days with the 2015 guidelines, and currently more and more of us are moving away from radioactive iodine. But if somebody is going in for redifferentiation therapies, and I'll come to it in a little bit, or if they've already received 3 doses of radioactive iodine when they were younger, and now you're seeing them in their 70s, and you want to make sure you're not, giving them a second cancer. So that's when we do dosimetry before we give them their final dose of radioiodine. Now, we also consider inpatient treatment for those who require a very high dose of radioactive iodine. Every state has their regulations on what is the maximum dose. In some states, it is 200. In some states, it's 250. So if somebody is getting 250 millicuries, they have to be inpatient. They have to stay in a lead-lined room so that they are not exposing other people to radioactive iodine. Outpatient treatment is usually what is done because very rarely I see such high doses given these days. So we typically 100, 150, you can safely do it in the outpatient setting. Radioiodine is used both for diagnostic and post-treatment scan. I mean, we can use radioiodine for both diagnostic and post-treatment scans. A diagnostic scan helps us determine the empiric dosing. That means what lit up on the scan. Was it just the remnant after surgery? Or was there some disease elsewhere we didn't know of, like the lungs? Or was there a huge remnant? So that's a diagnostic scan. Or was there nothing that lit up? And then the post-treatment scans are different from diagnostic. The reason we do two scans, why do we do when we already know what we're treating with the diagnostic? Because the diagnostic scan is using a low dose. We typically give 2 to 4 millicuries. But when you do a treatment dose and do a post-treatment scan, this is after 100 or 75 or 150 millicuries. And in that case, you'll be surprised. Sometimes you don't see what lit up, what lights up in the post-treatment scan may not have lit up in the diagnostic scan. For example, lung metastasis. So sometimes we see lung lesions light up on post-treatment scans. That's why this is important. That's why the need to do two scans. Then we also talk about risks versus benefits. This discussion is important, particularly for young women who are planning to have more kids, because if you do, or even young men for that matter, because if you are planning to conceive, you have to be careful for the first 12 months. And if you do need radioactive iodine, you have to use, birth control methods so you don't conceive in the 12 months following radioactive iodine. Then again, risk versus benefit in somebody who's already received, like our previous patient, we saw 4 doses of radioiodine. Is that really going to help? He's already received so much. So it's good to have that discussion. But radioactive iodine definitely helps in the treatment of lung metastasis. So that is something we can, use for if we come across in our scans. So let's take a look at some of the iodine 131 scans. And like you can see here, this is what the lung lesions look like when there's uptake or when there's lung metastasis. And this is extensive disease, like they have something in the neck, something in the lungs. Again, pretty big remnant over here. And then this is a scan where barely minimal or maybe like a remnant is lighting up. Now, what you see here is physiologic. That means it's in the stomach, in the bladder. So we don't get worried by this, but we tend to look at what is lighting up in the neck and in the lungs. A negative scan, like you saw here, does not necessarily mean that there is no cancer. It could mean that there is cancer which does not take up radioiodine. And that is important to understand because that tells you that this cancer is now progressing. It's not your well-behaved, slow growing papillary thyroid cancer anymore. It's probably changing to something else. Or this could be iodine non-avid disease. That means there's no point in giving more radioiodine. So utility of the post-treatment scan, like I said, so this was the diagnostic scan in the same patient and the post-treatment scan after giving 150 millicuries, you can see that the lungs lit up. So that's why do not skip the post-treatment scan. I have a lot of situations where patients say, okay, if this is done, I need to get back to work. This is important, but this post-treatment scan is very important. So let's not skip that. And what is SPECT CT imaging? Sometimes your doctors may ask for a SPECT CT in the orders. So what it essentially does is it identifies a lesion which correlates with the post-treatment scan. For example, a lung lesion or a bony lesion. Like for example, on the CT scan, you can see there's a tiny nodule here and it is lighting up over here. And what is the utility of a PET scan? And for those who might have attended Dr. Alan Ho's lecture earlier, he talked about PET is nothing but you give them sugar and you try to see what is taking up sugar, what is taking up glucose. And anything that is metabolically active, for example, your heart, your brain, they are going to light up on the scan. And so are going to be, pneumonias and lymph nodes that are inflamed from even an infection. So we don't typically do a PET CT for patients with, garden variety papillary thyroid cancer. But yes, if you have a negative diagnostic scan, or if your thyroglobulin is high, but you're not seeing anything on the whole body scan, then you want to do a PET CT, because there is something making thyroglobulin. You just don't see taking up iodine, and that's where a PET CT comes in handy. So these are some false negative PET CTs, and that's one of the reasons why we don't like to order it routinely, because you see the CT scan shows a lesion over here, but that doesn't light up. What does this mean? Why isn't it lighting up? Anybody in the audience? Because it's not growing rapidly. It's slow growing. It's not very hungry. So growing kids, they're always hungry, right? They're constantly eating. Same thing with growing tumors. So this is not taking as much glucose because it's been there for a long time. It's most likely going to be there for a long time without growing much. So that's why a PET CT is not super helpful. Now let's look at the evolution of advanced thyroid cancer treatment. I know this was a topic on initial diagnostics and treatment, but I couldn't help myself. I treat advanced thyroid cancer. So apologies for the information overload. Feel free to stop me and ask questions, okay? So this is where, initially we started off with 1930s thyroid hormone, 1940s radioactive iodine. We read about the story of it. And then came the chemotherapy with doxorubicin. We don't use it anymore. 2000s were the era when we started seeing TKIs, the sorafenib, lenvatinib, and now we have more TKIs available like dabrafenib, trametinib. We just had a very good lecture by Dr. Konda who talked about these drugs. And then the larotrectinib and entrectinib. And these are targeted therapies. Remember the busy picture I showed you with all the mutations earlier? Why? That's what runs in our head, because we now actually have treatments targeting those mutations and fusions. And why is it important? Because they don't have as many side effects as this doxorubicin has, or for that matter, even as sorafenib has. So that's what's important to understand. What can we help our patients with? What are the targets we should look for? Because there are drugs available. And then we are also looking at combination therapies, redifferentiation therapies, mutation targeted therapies, and then immunotherapy, the hot topic of the day, right? We don't have much for thyroid cancer just yet for papillary, but it's being studied. So what are the FDA approved treatments? And you can see here that previously they used to use doxorubicin because there was really nothing else available. But over a period of time, with vandetanib was the first drug, which was a multi-kinase inhibitor. That means it worked on multiple receptors. It was first drug approved for thyroid cancer. That was for MTC. Then came cabozantinib. And then for DTC, or differentiated thyroid cancer, that's your papillary and follicular, you had sorafenib in 2013, followed by lenvatinib. Then you have dabrafenib, trametinib for ATC, not for papillary thyroid cancer, but it was approved for anaplastic thyroid cancer. And then you have these NTRK inhibitors, that is your larotrectinib, entrectinib, which were then approved in 2018, 2019. So again, looking at, so these are the commonly used drugs, and I highlighted them and I've specifically put them here so you can see where they target. You don't need to know that, but this is why we do molecular testing. This is why we request molecular testing to identify what can we target, like red PTC. So you can use, so lenvatinib, cabozantinib, it works on these mutations, right? And then you also have the pralsetinib and selpercatinib. Those are also available, which I've not listed over here, but selpercatinib is, again, it's an agnostic indication that we call it, but that is used for anybody with a RET mutation or a RET fusion. So RET fusions are rare in PTC, but we still see those. So we should look for those because you have a drug available for that. Then you have cabozantinib, here lenvatinib. We also have dabrafenib, trametinib, which again, we are not talking about here because the focus is anti-angiogenics. What that means is it's basically targeting the blood vessels. It's targeting the blood vessels which feed the tumor. So what is the most common side effect for these drugs is bleeding, right? Because it's basically targeting blood vessels. So you see there's a risk for bleeding, there's a risk for high blood pressure. So that helps you understand what these drugs can do from when you understand what the mechanism is. Then we talk about redifferentiation therapy. This is a hot topic, right? Like we talked about those 4 radioactive iodine doses that gentleman got. And then we talked about toxicities of radioactive iodine. And now we are getting more creative because the tumor is getting smarter. The tumor is developing mutations which makes it less responsive to radioactive iodine. So let nobody give you more radioiodine than is necessary because you have these options now. So what are these options? So these are drugs that we use. They target these specific mutations. Why? Because tumors that have a BRAF mutation, they don't take up radioiodine very well. They don't respond to radioiodine very well. So what's the point in giving somebody more and more radioiodine when you know that it's not going to respond, right? So in that situation, what we've started doing is these 2 other drugs which have been studied, but compared to vemurafenib, dabrafenib has a better response. So your doctor may use dabrafenib for 1 or 2 months and then give you radioactive iodine. And you can see here that in the pre-treatment scan, you don't see any disease. But in the post-treatment scan, you can see that the lungs are lighting up. Again, pre-treatment looks clean, right? But post-treatment, you can see they're lighting up. So this was published in JCM in 2018. This came from our center, MD Anderson. But we found that patients who were not responding to radioiodine previously, when you treat them with these drugs, they were able to take up radioiodine. And there was also a clinical trial out of MSKCC, which looked at selumetinib. We also used trametinib. Even cobimetinib has been used in some situations. Then the hot topic of the day, immune checkpoint inhibitors, right? Immunotherapy, there's immunotherapy for everything. Is there immunotherapy for thyroid cancer? Yes and no. So when we studied papillary thyroid cancer, follicular thyroid cancer to see how hot or how immunogenic the environment is, will it work? Sadly, we found it won't. But in aggressive thyroid cancers, like your poorly differentiated or anaplastic thyroid cancers, they have a lot of immune markers, and your doctor may check for that. And if they do, that's when you recommend using immunotherapy. But again, it's not FDA approved. So it is challenging to get, and there is a need for more data to come out so they can be easily accessed. All right, with that, I end my slides, but I'm happy to take any questions. Yes. Perfect.
So I have multiple, but
yes.
So if you have papillary and the treatments doesn't work.
So that's a good question. So the question was that if your treatments for papillary thyroid cancer don't work and they progress despite treatments, do they become poorly differentiated or is it a separate entity? It can become poorly differentiated. It can still look like papillary, but now it may have acquired more mutations, which makes it more aggressive. So it may not say, like when you look at the pathology, it may not say it's poorly differentiated or undifferentiated or anaplastic. But the molecular makeup comes in handy because those are the tumors which go from having, say, 2 mutations to multiple mutations. And that's why the higher the mutation burden, the less responsive or more aggressive those cancers are.
And then how would you because you had mentioned the molecular testing, like just to give my example, when I had my thyroid removed, they didn't do molecular testing on my thyroid.
How long ago was that?
They removed mine in February 2021.
Okay.
And so they hadn't done it. And then I went to see an endocrinologist and they asked me for
moleculars.
Yeah.
Okay.
And I was like, oh, trying to get it from the hospital. They're like, oh, we didn't do it. They then said that 9 months later they did it. So based off of the 9 months later, I did have the BRAF.
The BRAF mutation.
Or yeah. But how, like, could pathology really last for that long that it could be tested so many months later?
Absolutely. Yeah. So that's a good question. The question is that how can the test still be valid so many months later for molecular testing? The answer is yes. We even test moleculars on tumors from years ago. So like, 20, so we are in 2023. So 2013, 2014, even those tumors, you can go back and still do molecular testing on those. Now, while we talked about molecular stuff, unfortunately, insurances don't cover it. So it's not a standard of care. It is something that we look for when we see advanced thyroid cancers or something that is coming back despite radioactive iodine, but it is not the first thing we do on a pathology, unfortunately. And the guidelines don't recommend that, because if you really think about it, the majority of these differentiated thyroid cancers are well behaved, slow growing. So it's the, the utility of those tests. But yes, you could go back and do molecular testing if it's necessary.
If, like, let's say they once they, let's say they remove your thyroid, right? You don't have a thyroid anymore. Then the nodules that you still have there, would they still biopsy those with the fine needle? Like, that still be done even though, or whatever, like, let's say hypothetically there's a potential that they either left like a remnant tissue or it's cancer that grew. Like, could you test that with
With the FNA? So the question you're saying is that if there is something that we see on imaging, like a remnant or a nodule in the thyroidectomy bed area, can you test it with an FNA for whether this is cancer or not? We can. The simple answer is yes. The difficult answer depends on the size. So if it is really small, and if it is going to be an access issue, for example, if this nodule is close to a blood vessel or it threatens vital structures, then we may just monitor it to see if it's growing, because a lot of times it's just scar tissue, and scar tissue there's no point in biopsying because you'll cause bleeding, patient discomfort. So if it is a big size, like if it is over 1 centimeter, 1.5 centimeter, then I would probably be curious to biopsy it. But again, we always ask ourselves, curiosity and academic information is one thing. What are you going to do with that information? Because at the end of the day, we are putting patients to discomfort, right, for to answer our curiosity. So if it is going to make a difference in your management, like, or your treatment, for example, if we need to tighten up the TSH suppression, you don't need to do that after a biopsy. You can do that even before, right? It's not going to, if you're suspecting a recurrence. You really want to do that if you are worried about, large disease that has come back, which needs surgery, or do we need to give you some chemotherapy to shrink the tumor before you take them up for another surgery and things like that. So we don't routinely do a biopsy unless if either the patient requests it, then obviously they are asking for it, but provided it is safe. Because sometimes if it is close to the carotid, I would, counsel them like, listen, I'm more worried about a carotid puncture than, the cancer.
Let's say a person, and by person I mean myself, if you've already done 2 treatments, 2 RAI treatments, and you've done, let's say, the 2 diagnostics before, how do you know whether you are RAI resistant or like whatever, it's advanced versus they didn't give you enough?
Very, very, very good question. Thank you for asking that. So the question is that, say you received 2 treatments and you want to know whether your cancer has not responded to it, or you haven't received enough response, or when are you RAI refractory, right? Yeah. So that's a very good question. It's actually been defined in the ATA guidelines that we use. And it means that if there is a disease that you see structurally, that means on a CT scan or a SPECT scan, and it doesn't take up radioiodine, it's considered RAI non-avid or refractory. RAI refractory is also that refractory means it is not responded to treatment if despite radioactive iodine, it has grown in size. Or say you have 6 lesions, of which 2 take up radioactive iodine and 4 don't, or 4 take up radioiodine and 2 don't. Then you are looking at, okay, this is turning radioiodine refractory. So it's not about that you haven't received enough. It hasn't, what it means is that this cancer is not responding to radioiodine. So you may have received 100, you may have received a 75. The goal of radioactive iodine really is not curative. It's basically, resetting the disease to 0. So when you follow thyroglobulin or ultrasounds, you know that you're starting from scratch. So it's not very curative unless if it is for like lung metastasis where it's diffuse and it shrinks those lesions. So yeah, so that's a very valid point. So it depends. That's why we do the SPECT CT to identify those non-RAI responsive lesions.
And if on your scan, if it says if you have the same, because you had mentioned, it's like like, you know, when they give you thyrogen, like let's
Yeah.
say your level is protect that your thyroid globulin is a 5, right?
Mm-hmm.
And then you get thyrogen,
Correct.
right? And then it makes it a 20.
Correct. Uh-huh.
If it's like that, but it's always this, your thyroid globulin is always the same every time you do your treatment. But on the scan, they say something different, like they see something else
Mm-hmm.
or recurrence. Would you say, in your medical opinion, that that person potentially would then have an advanced, or it's still unknown that you have to do more tests?
Just to clarify, and probably you're asking two questions in one, so that's okay. But I just want to clarify the question for the audience and as well as for my own understanding. You're saying that if you have a detectable thyroglobulin with TSH suppression, and you give thyrogen or you do withdrawal, and it shoots up to say 20, right? You said give an example of 5 to 20, and then you're saying if you see something on scan versus if you don't see something.
Yeah.
Okay. So if you see something on scan, then the structural disease is correlating with what we are seeing. And if the person hasn't received enough radioiodine previously, you could give them more radioiodine. If you don't see, that is, if structurally you don't see anything on the scan, but you see this thyroglobulin has gone up after withdrawal or stimulation, that tells you that it's not taking up radioiodine. Then you go on to PET CT or you look at the SPECT CT to see what it is.
Could there be, because I was told that, like, even in the beginning, that your healthy thyroid tissue and thyroid cancer can both produce thyroglobulin.
That is correct.
So then how would you know, like, if it's like a bad versus a good?
Absolutely. So the question is that healthy thyroid tissue and thyroid cancer makes thyroglobulin. How do you know that the thyroglobulin is coming from?
Yeah, like I'm asking, like, what if when they did your surgery,
Mm-hmm.
by mistake, they left a little bit of healthy
Thyroid tissue. That's a good point. So that's why the ultrasound comes in handy. The ultrasound helps you, determine if there is something there. That means if there's a remnant. For example, in patients who have a lobectomy, they still have an intact thyroid gland, right? They at least have one lobe. So we expect their thyroglobulin to be detectable. But in somebody who's had a total thyroidectomy, if the report, you look at the operative report, you look at the pathology report, if it looks like they've taken out the entire gland, and you're still seeing a very high thyroglobulin, that means there's something left behind.
What would be considered a high?
I mean, that would be like either a thyroglobulin, the suppressed thyroglobulin more than 1, or a stimulated thyroglobulin more than 10. So we typically wait at least 8 to 12 weeks after surgery to check the levels, to check a true nadir in the levels, because if you check it sooner, you will see a thyroglobulin because it tends to linger around. And what makes it worse is the thyroglobulin antibodies. Those don't go away for years sometimes. So that's why we have to, take this information with a pinch of salt.
We do have a question from
Yes.
Zoom. What amount of RAI is safe? And by safe, I mean no risk of secondary cancers. Is there an amount?
So the American Thyroid Association guidelines give us a cutoff of 600 millicuries. So typically patients should not exceed 600 millicuries of radioiodine. But at the end of the day, there are people who've received 3 and 4 doses historically when we didn't have anything beyond doxorubicin. And those are the ones we see some, lymphomas, bone marrow suppression, and some secondary cancers. But there is the maximum toxic dose is 600 millicuries. So that's that one thing I really, there's one take home point is make sure you get a very good surveillance ultrasound, looking at lymph nodes. Because a lot of times some centers, they only focus on the thyroid bed area, and part of it is because of the way the ultrasound is ordered. Some doctors will order ultrasound thyroid, which means it'll only look at the thyroid. Because the radiologist doesn't know your history. He's just following the orders, or the technician is just following the orders. So we should ask for an ultrasound of the neck where they look at all the lymph nodes, because that's where that disease could be hiding. That's where it can easily get missed. When would you consider redifferentiation therapy, right? In somebody like you who has a well-suppressed TSH but a detectable thyroglobulin. So the question is, where is the disease? We don't chase numbers, we don't treat numbers, we treat our patients who are human beings, right? Because if you are considering either TKIs or chemotherapy or redifferentiation therapies, we should be sure that it's going to make a difference for the patient. Even if you have persistent disease, one can live with it. It's not going to kill you, but the side effects from chemotherapy can, right? So we really have to find out if the persistent disease is bothering the patient. First of all, where is the disease? So for example, if somebody is, just for an example, TSH is less than 0.1, but their thyroglobulin is 20, and you want to see where that 20 is coming from. Is it from the lymph nodes? Is it from the lungs? Where is it coming from? Okay, it's coming from the lymph nodes. Maybe there are 2 lymph nodes. What would you do in that case? Would you do more radioiodine? Would you give chemo, or would you watch? If it's 2 lymph nodes, first of all, if it's in the lymph nodes, it means you may end up needing surgery. But nobody will want to take you up for 2 lymph nodes, because the more surgery you do, there's more scar tissue. So in those cases, like the reason I talked about lymph nodes is because BRAF mutated thyroid cancer tends to come back in lymph nodes. So in those situations, we really wait and watch and allow the disease to declare itself. I have patients who I've taken on from physicians who've now retired. They've had cancer in the lymph nodes, cancer in their lungs for 8-10 years. They've not received TKIs. They've not had another surgery. We're just watching. They come once in 6 months. We do our usual social greetings. We scan. We look at, okay, it's gone from 1.2 to 1.4 centimeters. Are you having trouble breathing? Are you having trouble swallowing? No, fine, we'll watch it. But if the lymph nodes go from like 2 or 3 to now there are 8 lymph nodes, or the TG shot up from 20 to 60 or something like that, then you know this disease is growing, right? Then you want to do another neck dissection to address the lymph nodes. Lung lesions are interesting because for that, if you've already received radioiodine, we again watch those lung lesions, because a lot of times these lung lesions are like little dots in the lungs. They're not, if they're near an airway, then sure, you may want to do some procedure to, prevent it from growing further, because otherwise you'll have a pneumonia and collapse. But if it's not anywhere, then we just keep an eye on it. I have a patient, she has a 1.8 centimeter lung nodule, and we're just watching it. It has remained 1.8 centimeter for the last 3 years. It hasn't, but it's big enough to biopsy. But I'm not even biopsying. It's not bothering her. Sure, it is 1 point. You can biopsy, but what am I going to do with that information? I already know it is thyroid cancer, but it's not doing anything. So let's keep an eye on it. And if down the road it grows or she has more nodules, we could always revisit biopsy at that time. So a lot of it is wait and watch.
Thank you.
Sure. Yes, ma'am. So are you asking that if they have papillary, do you follow them to see if they develop follicular down the road or medullary down the road? It's very unusual. That being said, yeah, a lot of people have both. I have had patients where they have medullary and papillary, but the medullary is an incidental finding. It's like a 0.1, or the medullary is the bigger one and the papillary is an incidental finding. So in those cases, we look at thyroglobulin and calcitonin. And again, depends on what the pathology shows. If the papillary variety was more invasive or with lymph node involvement and stuff, then we follow them from the papillary standpoint. But we do keep a watch on the calcitonin levels as well. We don't see it very often, but I can exactly tell you I have patients who have had both. I had one anaplastic thyroid cancer patient, young man. He had all 3. He had papillary, medullary, and anaplastic and wow. He didn't make it. What is that? Yeah, he was fairly young, 47 or 48, and he had this rapidly growing mass. And so he was referred to us after he had 2 biopsies outside. One showed medullary, one showed papillary, and when they sent it to a higher center, they read it as anaplastic. So then they were like, okay, what is it? And when we looked at all the slides, interestingly, he had all 3 of them. So that's rare, but we do see that happen. And that was not good, of course, but it's very rare.
We do have a couple minutes left for any last minute questions.
Yeah, I'm getting hemithyroidectomy done in October. What are the chances of recurrence for 1 centimeter PTC with no spread to the lymph nodes? Can we rely on thyroglobulin in case of hemithyroidectomy, or ultrasound is the only best way to check for recurrence? Very good question, I think, because these days we are doing more and more lobectomies or hemithyroidectomy. So sounds like from what I'm seeing here, it's 1 centimeter with no spread to lymph nodes, very low risk for recurrence. It looks like it's probably just in one lobe. And if you're doing a hemithyroidectomy, then you just need an ultrasound. Can we rely on TG in case of hemithyroidectomy? We cannot. Although I will say that I do check a TG because it's not super helpful, but I think I'm a little biased because I see advanced thyroid cancer. I like to make sure it doesn't go from 12 to 48, something like that. But in low risk cancers, there is really no role. Like in this situation, I wouldn't be worried by TG because looks like it's very much on one side with no lymph node involvement. So the TG is not going to be helpful. It will only add anxiety to both physician and patient. So it's not helping anybody here. So I would just do a surveillance with ultrasound.
Do you know if there's any studies happening for solid trabecular variant of papillary?
It seems very, yeah, but their rates of recurrence, there are active studies for more information. The rare variants, they usually reported as case series. I don't have any active, clinical trial that I'm aware of for these, but usually at larger centers like MD Anderson or MSKCC, we have a collection of these cases, and then we tend to report them out when we find something significant. So I'm pretty sure cases are being collected and they'll be reported, but nothing concrete to the best of my knowledge.
And with that, it is now time.
All right. Thank you,
Thank you
Matt.
for your time, Priyanka, and
Oh,
thank you
my
everybody for
pleasure.
attending.
Thank you so much for your patience.
Thank you so much.
My pleasure.